Good afternoon, everyone. Thank you for attending today's speed briefing on how to reduce out-of-pocket healthcare payments. My name is Anika Stobart, and I'm an associate in the Health and Aged Care program at the Grattan Institute, and with me is Duckett, the director of that program. So before I begin, I would like to acknowledge the traditional owners of the land we are on today, the Wurundjeri Wurrung people of the Kulin Nation, and pay my respects to elders past, present and emerging. We do have a Q&A button, so if you have questions throughout the presentation, please put them in the chat and we will endeavour to get to them. We will have a few minutes for questions only, given it is a speed briefing. So before I begin, I'd like to first define what out-of-pocket payments actually are. So this is the money that people pay upfront for healthcare. So for Medicare subsidised services, it's the difference between what a healthcare provider charges and the rebate paid by government. Our report specifically focuses on medical services and pharmaceutical medications. Grattan has previously published reports on private health insurance and dental care that address other healthcare out-of-pocket payments. So Australia's Medicare scheme is generally good. As Australians, we take pride in our healthcare system, and overall, a lot of people don't face high costs for healthcare. If you have a look on the left-hand side here, this is the proportion of healthcare services that are bulk billed by service type. So you can see, for example, GPs have quite high rates of bulk billing at about 80 to 90%. But we are still paying out of pocket for a lot of services. You can see on the right-hand side there that a lot of Australians are spending money on specialists, and it amounts to about $1.3 billion a year. And if there is a high barrier to access because of cost, this is a problem because people get sicker, they decide to skip care or delay their care, and that also puts then health pressure on the healthcare system down the track. You can see from this slide here that there are about 500,000 people that say that they skip medication because of cost in 2020 to 2021, and the same with specialists. And you can also see that in the red there, most of these people have chronic health conditions. So we looked at Medicare data and also expenditure on pharmaceuticals, and we found that people that have chronic health conditions spend more on healthcare than people without chronic conditions because they have ongoing healthcare costs and need different types of services. And in particular, if you have a look, the more chronic health conditions that someone has, the more they're spending. So with people who have 3 or more chronic health conditions, like asthma or diabetes, they're spending up to $1,500 on these on healthcare services each year. And if we look at the demographics as well on the people that say they're skipping care because of cost, it's mostly younger people that are reporting this, particularly younger women that are there in the red line. And this might be because younger people have lower savings and wealth, and women are particularly more likely to have multiple chronic health conditions. And it's particularly a problem with prescriptions and specialists. GPs in generally, most people don't report skipping GPs because of cost. So let's have a look at the services where people are spending. So for prescriptions there on the left-hand side, generally in a year, people are spending about $80 on prescriptions, but the average doesn't tell the full story. You can see there is a huge variation, with some people paying up to $400 per year on just their prescription medication. And these people are more likely to be people who have chronic health conditions that have ongoing prescriptions that they need to take. You can see as well that allied healthcare has a huge variation in expenditure. So these are services like seeing a physio or a psychologist. And there on the far end, you can see specialists. There are 5.5 million people who paid for specialists in 2019, and they pay at up to $400 over that year for specialist services. So this is quite a lot of money for a lot of people. Now let's look more closely at specialists. So if you need to see a specialist, you can go to the public system. So they're called public outpatient clinics, where you can put your name on the waiting list. But you can see here that the waiting list is incredibly long for a routine initial appointment for a lot of specialties. And we have data only from Victoria and Queensland. We can see that many people have to wait a year or longer to see a specialist, which is unacceptable. So people are then forced to turn to the private system. But because fees are unregulated, providers can charge what they like for the service. So we have the Medicare schedule fee, which is what the government determines as a fair price for a service. And then the specialist can charge either a bulk bill, so the amount of the rebate, so that there's no out-of-pocket for the patient, or they can charge more. And you can see here in the red that there's a lot of services for initial appointments are charged at more than double the schedule fee. For example, if you have a look at dermatology at the top, there are about 70% of initial consultations in 2019 were charged at more than double the schedule fee, meaning that patients are paying a lot out of pocket. But this does vary by specialty type, as you can see here. I will now turn to Stephen, who will run through the recommendations of our report.
So thanks very much, Anika. So what we've talked about so far are the problems, and we've shown quite clearly that people miss out on care because of cost, and they pay a lot for it. So just starting with specialists, there's not one simple answer, but part of the answer is more services. And so what we've suggested first and foremost is that the public option, public hospital outpatient clinics, should be expanded. Now, outpatient clinics are good because they also provide a place for training of future specialists. Now, you don't have to provide, we've said, well, how much do you need to expand? We said, yeah, let's talk about a 10% expansion of public hospital outpatients. You might not have to do that much if you can make them more efficient, if you can have an increased ratio of new patients to review patients, for example. The Commonwealth Government needs to step up as well. And what we've suggested is there be more bulk billing specialist clinics. So rather than in the hospital, we establish bulk billing clinics in a general practice, a bulk billing general practice, target those to areas where there's low bulk billing of specialists, low income, and so you can actually expand a private option. Now, you probably have to subsidise these because, as Anika said earlier, only about 48% of out-of-hospital specialist attendances are currently bulk billed, so you might need to put in a subsidy. But again, we're suggesting a pilot program involving 10 primary health networks. I'll declare an interest. I chair a board of one of those to actually see how you can do it and what you get for your money. We also say, well, why don't we try and reduce the number of specialty consultations all up? And one way of doing that is to actually pay a specialist to talk to a general practitioner about a particular client and to write a report about that. And so the GP has their skills built up. The patient doesn't have to go to the specialist and actually pay the out-of-pocket, and so we benefit both primary care and the patient by getting improved advice. And we think, even though the GP is probably still going to have to refer maybe 10% of the people that they talk to the specialist about, there's still a good benefit in that sort of strategy. Also, we want to help the GPs make more informed decisions about referrals, and so we want them to have more information about the charges that specialists are making so they can help their patients go to the right sort of place. Turning now away from medical specialists to prescriptions, there are a lot of patients who have more than 5 prescriptions. Obviously, we've talked earlier, Anika showed you the data about people with more chronic diseases have more out-of-pockets. One of the ways of trying to reduce the out-of-pockets is to reduce the number of prescriptions. And so you say to the GP, look, our computer shows that this person has more than 5 prescriptions and there may be contraindications. So could you do a review, please, of the pharmaceuticals? And if the patient still needs 4, 5 or more prescriptions, then you reduce the co-payment they have to pay because all of those have been deemed on review to be necessary. Diagnostic services, these are run by big businesses now. So a fee-for-service professional model, uncapped and so on, is really not the way to pay for it. What we're saying is pathology, radiology and radiotherapy should actually go to tender. Big corporations are doing this, go to tender and say, as part of the tender, let's see what price we're going to get. Pathology is almost all bulk billed already, radiology high. So we can actually sort of drive down and so say there's going to be no out-of-pockets. Patients are not the consumers of these services, GPs are. So let's try and remove the out-of-pockets altogether. Allied health, we're proposing a somewhat similar model. We don't think we'll get it down to 0 out-of-pockets. What we're saying is get down to lower the average out-of-pockets, but again have a system where the primary health network goes to tender in this case to say, can we get allied health services with lower out-of-pockets for people who need it? And finally, what we're in the medium term, we're saying that there should be expansion of voluntary enrolment. At the moment, the government has committed voluntary enrolment for people over 70. We think it should also be extended to people with multiple chronic conditions because they're the ones that need that continuity. They're the ones that need to be actually supported in this regard. So there are our recommendations. In a nutshell, the report is an easy read, won't give you insomnia. So we recommend you read the report, but also we recommend you support Grattan to help us do future reports of this kind. So thank you very much.
Thanks, Stephen. So now we have a few minutes for questions. So firstly, I'll go to Andrew Buncombe, who asked, do we think that there's any chance for reform of any sort to proceed in this area, Stephen?
Andrew, we wouldn't have written this report if we didn't think there was some chance of reform. And the reality is, even today, I've got these stories on Twitter, I've got emails about people saying, this is a real problem for me, this is a real problem for my community. So we've touched on a nerve here amongst patients who are saying, yes, it's a serious issue, and they like the recommendation. So I'm hoping that it will be picked up in the election campaign, or maybe not in the election campaign, but the new government will actually say, yes, Medicare is good, we know it's good, but we want to make it better.
Great. The next question is from James McAdam, who has asked, did we consider non-Medicare out-of-pockets, such as accommodation or parking? These can be considerable, particularly for rural and regional patients.
Absolutely. And so we didn't do that, partly because we didn't have good data on those sorts of things, but we acknowledge that the cost of going to a doctor, the cost of going to an outpatient clinic includes the cost of getting there. And I was talking to someone in Mildura this morning on this very issue. And of course, there are no outpatient services in Mildura. They have to go to Bendigo or Ballarat or Melbourne. And so, yes, there is an additional cost that we weren't able to take into account.
Although recommendations around telehealth as well would reduce those kinds of costs for those people.
Good catch. Yeah, we did recommend expansion of telehealth when we've evaluated just what's been happening now.
Great. So the next question is from Christabel. They asked, if we tender for services, how do we ensure quality? Often, for example, cheap radiology is not the most specialist or best in my area.
Absolutely. So a tender nowadays, when you go to tender, you just don't go on price. You go on price and quality. We've suggested, for example, in those tender arrangements, that you actually incorporate getting more information from the bodies that tender, and also capture patient-reported experience, for example, with the allied health personnel. So absolutely, it's important to factor quality into the equation.
And just to follow on with that, JH asked, if we tender for pathology and radiology, who's doing the tendering?
Well, I think there are a number of options. I think we're a bit unclear about that, but it could be the Commonwealth centrally in Canberra, and I think that's probably the right way to go with the pathology and radiology and radiotherapy. Or it could be a PHN, for example. But I think a centralised tender, you wouldn't tender for the whole of Australia. You'd say we want to tender for each, say, primary health network area, because you want to keep competition going. You want to not just have one pathology provider in any PHN. You want to keep the competition going, partly about keeping the market alive, partly about this question that I think Christabel raised earlier about quality. So in those cases, I'd go Canberra, but in the allied health, because you want to look more at the interrelationships and the networks and so on, you're going to be having more people being successful tenderers, I'd probably go to PHN.
Great, thank you. The next question is from Alison Branley, who asks, when it comes to specialist out-of-pockets, do you think there's merit in bulk billing incentive payments or a cap on Medicare thresholds, i.e. no more than 100% the Medicare schedule fee?
We recommended that in the medical specialists that you move over time to no more than twice the schedule fee. In some of those, we didn't actually say the schedule fee is wrong, but there's so few doctors bulk billing that you think, no one is accepting it. We didn't want to we haven't said anywhere that the schedule fee is always right. Second point I'd make is that, yes, we do, as I said, we do want to actually, first of all, provide information to the GPs about what the specialists are charging. And if that information strategy doesn't work, let's go with a cap no more than twice the schedule fee. I think that's one of the things that could help to drive those out-of-pockets down. And I think we had some other recommendation as well, which is about addressing that. The bulk billing clinics will actually help to force a bit of competition into the market as well.
Great. On that point of bulk billing clinics, Linda asks, how do the bulk billing specialist clinics work? Do the specialists need to agree to accept the Medicare schedule as the entire fee? Most specialists will agree that this won't be enough.
Yeah, so again, we haven't said anything about adding an incentive into Medicare. We've targeted this to areas of low income, low bulk billing rates. And we recognise that you might actually have to pay a supplement. You might actually say to junior specialists working there, look, we're going to waive any HEX debt, for example, you have. You might actually provide a bit of an incentive through a payment for the capital, the rooms and so on. So yes, we recognise that you may not get them to be precisely the bulk billing rate, but you provide some incentives in a tailored way in each different location. It might be different. You might have to pay different in rural as you do in metro and so on. So not a one-size-fits-all strategy, but one which is targeted and tailored. And again, you'd actually have specific specialties that are in that you might want to focus this on in the first instance.
Sharon Naidu asks, do you think part of the reform is to get patients attributed to a GP, similar to the UK, to help navigate through the healthcare system and to guide where to get efficient care?
I think that's a primary care strategy. We've actually recommended something similar to that in previous Grattan reports, and I certainly support voluntary patient enrolment, and I support as part of, especially in a system of chronic illness, where there's a greater prevalence of chronic illness, we ought to be encouraging continuity. We ought to be encouraging this sort of voluntary patient enrolment, and we've recommended an expansion of that to people with multiple chronic illnesses.
Daniela McEvoy asks, are cancer-related costs included in the data?
Yes, so we had a really rich data set which had information about every Medicare interaction, every pharmaceutical benefit scheme interaction, plus some data from the census and all sorts of other places. We didn't capture the transport costs and so on that someone has previously raised, but we had it for all patients, including radiation oncology and so on. So we used the 2019 data in our analysis in this regard, partly because the 2020 was affected by COVID, but that later data is there. But yes, cancer's there, and we show in one of the graphs in the report about different costs for different illnesses.
Great. Maybe one last question from Basmala, Australia. They asked, will moving away from fee-for-service model towards bundled payments, etc., help improve the out-of-pocket burden for consumers?
Basically, what the whole report is reducing the out-of-pocket burden for consumers. We do multiple strategies, some of which stays with fee-for-service, some of which is bundled payments. So I'm a supporter of bundled payments, blended payments, but not only that. So as I said, we've got still keep some fee-for-service, go tendering and so on. So it's a complex problem we're trying to solve. We've got a range of solutions. And I'd just like to thank you for being with us today to listen to this and for asking those really great questions.
Thank you very much for your time.